So this lecture is going to be about how we use models to make decisions. And I refer to this process as modeling for policy, and this is where computational or mathematical models can be designed to address questions posed by policymakers, clinicians, decision makers, and other sort of stakeholder groups. This requires a slightly different perspective than modeling for its own sake, or writing for a particularly academic math, ecology, or epidemiology audience. We haven't touched a lot in this lecture, but there are a great deal of modeling that's done essentially for primarily academic interest, looking at trying to understand a process, interrogating some findings, building theory and support for theory. And that's not what we're actually talking about here. What we're talking about is something where you have modeling tightly linked potentially with observational study or data or public health reports that are coming out. And both of those things are interacting very heavily with policy, and they're all helping inform each other in something close to real time. So the first question behind that is sort of, are models decision support tools? And the answer is no. But there's an asterisk to that answer. And that's because what a model is it's the simplified mechanistic version of how we think a disease process works. That doesn't necessarily make it a decision support tool, but it can make it the engine of a decision support tool and sort of something that lives at the core of a decision support tool. Often these things are so heavily integrated that we don't really realize they're separate, but it's important to keep in mind that they are, that your model and the decision-making framework built around your model are two separate things and can indeed be swapped in and out. This often does require some conscious effort and thought in terms of how you construct the model. What outcomes are you looking at? How are they presented? And then how fast do you need results? One of the things that's true in sort of an academic setting is that you have a little more time to think about sort of how you want to use your model in a very methodologically sophisticated fashion, making sure the results are published and things like that. In a decision support tool, especially during a public health emergency, the time frames where you need answers are potentially much, much faster, sometimes on the order of days. So the first step in thinking about this is the outcome. And really that is the question of, what are you trying to measure? Is that something that comes straight from your model? So something like the daily number of cases or your total outbreak size. Is it a calculated value? The number of days above ICU capacity? And an important step is to make sure that your model can capture the outcome of interest. That seems obvious, but that's important, especially if you're trying to take a pre-existing model and sort of move it into a decision support framework. What parameters do you need for something like ICU capacity? If you're talking about cost, which we'll talk about a lot later, where do you get the parameters for cost? The second step is to think about your decision options. So what are you actually asking about the decisions you can make? What choices can a decision maker make? I often refer to these as what dials can they turn? What's available to work with? Are these binary decisions, sort of go or no-go decisions? We should do this or we shouldn't. Are they discrete, where you have a couple options and you need to pick from that sort of menu? Are they semi-discrete? Things like how frequently should we test people? That's sort of close to a continuous variable, but not really, because you're still talking about, once a day, once a week, things like that. Or are they continuous? At what level of infection do we close schools? The continuous option, which is often very tempting, has some considerable methodological challenges to it. And both the economics, computer science, and operations research folks all have approaches to this that can help inform that particular thing if you really, really want to ask about a continuous potential decision point. The third step is compared to what? And this is scenarios can't be considered in isolation. If you think about a relative risk, a risk doesn't make any sense without a reference group. The same thing is true for most decisions. You need a comparison. Very often the comparison we reach for is do nothing. We often call this a baseline, which is I think a poor term for it. And what's important is to be very clear when this is the case, that what we're modeling against is choosing to do nothing. One of the questions you should always ask yourself is, does this make sense? So if we're in a setting where there are already interventions in place, maybe we should consider a scenario where we're using the interventions we already have, and that's the comparison. Is this something that we're potentially interested in? Remember, if we're talking about it, the option that we're going to do nothing might be unlikely. So one of the things is to make sure that people don't view this as a forecast, because a forecast implies that nothing will change, and the fact that you're talking about it is likely going to change things. So this is actually a really important step, deciding what your comparator is. So one method of this is risk analysis, which there's 4 parts to it: risk identification, risk assessment, risk mitigation, and risk monitoring. We're going to talk about assessment, but modeling can touch on all of these. And this is really just asking, what is the likelihood that something we're worried about happens? So here it's important to distinguish between uncertainty. So that's where we're not sure of the value of a parameter, or we believe the parameter is drawn from a distribution, versus variability, which is that the system itself is inherently stochastic. And probabilistic risk assessment asks about the probability of certain events. Will an ICU be overwhelmed? Will we see an outbreak of more than 10 people? And what we do is we model the event many times, incorporating uncertainty, variability, or potentially both, to understand the distribution of an outcome. So this picture on the left, which my head is blocking a little bit of it, is a very simple example of that, where what we asked is, given the information we knew about the West African Ebola outbreak, what is the probabilistic size of an epidemic? How often will we see very large epidemics compared to small epidemics? And so what we did is, in this case, we didn't do uncertainty. We said, what if all our variables are known, but we just want to know about the stochasticity of the system? We ran this several thousand times. We get this nice distribution of final epidemic size, and we can see that, generally speaking, the parameters we had for the Ebola epidemic give us very small epidemics or very large epidemics, and not a whole lot in between. So another way to look at decision support is cost effectiveness and cost benefit analysis. Cost effectiveness analysis, or CEA, and cost benefits analysis, CBA, compare the expense of an intervention with its outcome. This has obvious appeal for policymakers. Dollars saved is a thing that you can take to constituents, and it makes sense to them. And then budgetary constraints are a very real thing. If you're saying, look, I only have $5,000 in my district's budget this year, which of two things do I do? That's an important question to be able to answer. This is true if you're talking about things like hospital-acquired infections, where hospitals are trying to save money. And the question is, will this save us money in the long term? Or if it does cost us money, how much money does it cost? These are often very difficult to parameterize, and you can often get into fairly murky ethical waters when you think about things like, you shouldn't, for example, run the cost effectiveness or cost benefit analysis of something like, is it not worth doing this for a certain group of people based on protected classes and things like that. For both of these things, you need cost, but this is often trickier than you assume. So if you say, what I have is, I'm looking at a vaccine campaign, and the cost of a vaccine to buy it is $1.47. But what is the cost of the -80 freezer it needs to be stored in, the cost of shipping it, the cost of the person to inject it, the cost of the facility where you can do that injection? Do you have all those things? Those can often be very, very large components of cost, and you need to think about them. And the supply chains for a lot of public health interventions are often extremely complex. And so actually wrapping your head around costs can be quite challenging. So for cost effectiveness, what we do is we compare the cost and benefit of a proposed action with a reference group. So for example, if we're considering deaths, we look at the cost of the intervention minus the cost of the comparison, the deaths in the intervention minus the deaths in the comparison, and you get the cost effectiveness. What you get from this is the cost per death averted. And the outcome can be used, and we often see what is called quality adjusted life years, which is this sort of construct based on average mortality as well as long-term consequences of disease. So both how much longer did you live with this intervention, and then what were the sort of quality of those years in terms of potential long-term disability and things like that. It should be noted, however, that qualities are very difficult to calculate in many cases, and they're controversial in many communities because they involve inherent judgment as to what is the quality of a life. If you say, you'll survive for one more year, but we're going to give you a quality of 0.5 because you've experienced some disabilities, you're saying your life has roughly half the value of someone who doesn't have that collection of disabilities. That can be a very problematic statement. And so a lot of stakeholder communities end up pushing back on qualities often quite strongly. For cost-benefit analysis, there's a lot of pitfalls here as well. So here what we do is we have to attach value to the outcomes, and this can be very fraught. The nice part is it does allow you to wrap multiple outcomes into a single analysis, because as long as you can sort of bundle all the costs together, you get a number. But there's a very easy example of this, which is, what is the dollar value of a human life? There are purely monetary approaches to estimating this, but there's one that touch on human value. So for example, if you talk to the legal profession, the value of a human life has a lot of emotional weight to it if you are talking about jury trials, things like infants and young children, end up having a lot of value attached to their lives, whereas often there's a lot of economic analyses that look at things like what is going to be the cost of continuing to raise you, and then the cost of your, the benefit of your lifetime earnings and things like that. And you can sort of somewhat more less emotionally calculate those things, but those are value judgments, and so you often get those things sort of wrapped up together. And in economics, there's also what's known as the problem of discounting, which is the value of something is reduced the longer it takes to see that benefit, the idea being that money could have been spent on something else. This is often expressed as what's called net present value. The equation for it is here. If you want to talk about that a lot, I suggest talking to Megan about it or finding your local business school or economics department. But the thing to note here is that you have this discount rate R, which is often an interest rate. And what that does is that erodes this value over time. A lot of infectious disease programs suffer from this because they require massive upfront investments. Vaccination campaigns, if you're talking about a lot of gastrointestinal diseases in the developing world, massive infrastructure investments, things like that, for what is ultimately a very long-term benefit. This can make them look very unattractive. And so one of the things you have to think about is, what is the time frame you're looking at? What is the appropriate discount rate to use on things like that? So again, this can be very methodologically challenging. The final thing to touch on in this is what's called multi-criteria decision analysis, which is what happens if you have multiple things you want to optimize. MCDA creates a variable that's sort of a construct of all of your outcomes weighted by importance, and then you optimize on that. So maybe there's a really important outcome that we can't avoid, but if we can avoid tons of less important outcomes, that might be okay. Changing the weight here is relatively easy to do, and this can be useful when discussing a problem with multiple stakeholder groups. So for example, do clinicians weight outcomes one way, but community groups another? You can sort of interrogate those weights and see if you can find a balance. There's also ways to optimize on multiple objectives without creating a conjugate variable like this, but these are very computationally tricky, and again, probably require, in many cases, the assistance of someone in computer science or operations research or something like that, where these sort of multi-objective optimization problems are something they think about quite deeply. So that's the end of this, and we will see you in another lecture.